Good evening, everyone, and welcome to the New Frontiers in Neurosurgical Education and Training webinar. This is a collaboration between the AANS and the FLANC organization. It is led by the AANS Global Committee, and my name is Isabel Germano. I'm the chair of the committee, and I would like just to introduce the scope of the committee, as well as to thank the members of the committee for all the hard work that they do. The scope of the committee is to put our efforts together as a group of neurosurgeons trying to connect and facilitate neurosurgical efforts across the globe. And with that goal, tonight we are very excited to have this collaborative effort between the AANS Global Committee and the Latin American Society of Neurosurgery. Professor Borba joined us, and he is a co-organizer of this event. So Professor Borba, if you would like to give a few words, that would be awesome. Thank you.
Thank you, Dr. Germano. Thank you, the AANS opportunity to be here. On behalf of our president, Marcelo Centeno from FLANC, that not be able to participate, I'm here to represent him in this webinar. I have a great pleasure to have our great friend and neurosurgeon from Argentina, Pablo Achler. He's the chairman of the Hospital Italiano in Buenos Aires, a very well-known neurosurgeon and educator around the world. We're waiting Professor Juan Luis Gomez Amador. He told me that he's waiting to get the link to be panelist. Maybe something he's waiting online. And my chief resident, Guilherme Secato. Guilherme is a young, bright young guy that is running our lab in microsurgical technique. He's developing new ideas. So that is possible with new ideas and creativity. You can do everything in any part of the world. Thank you, Isabelle. Thank you, AANS, and thank you, all the team. I see here Professor Burney. It's a pleasure to meet you. I met you a long time ago in Egypt. Now you're in your new home in Jacksonville. Enjoy the Florida, the beautiful weather and the beautiful sun. Thank you.
Thank you, Louis. So we're going to start with Professor Rich Byrne. To introduce him, it would probably take the full hour for the seminar. So I'm just going to say that he has been a pillar for neurosurgery, neurosurgical education, and currently is the president of the Society of Neurological Surgeons, which is the American society that deals with education, among many other things. Rich, if you don't mind grabbing the screen and start the webinar. Thank you.
Great. Thank you very much, Isabel and Luis and everybody. I'm pleased to be here. This is very much a topic on my mind. I spent a lot of time training residents and trying to come up with innovative ways to train residents and to get better like we all do. I have a few slides here, and I think we'll hopefully have some time to talk, but just a few things to stir conversation. The first thing is, we've been pioneering, and as have other people here, all sorts of different ideas in simulation training. Simulation training has really evolved from simulated scenarios to simulated procedures to haptic-based AR, VR simulated procedures. Hopefully, we'll be hearing from some of the other panelists about this today. I won't be talking much about that. I still think there's a lot of role for all of these techniques. I'm going to talk a little bit about just evaluating surgical technique. And some of it is just old school evaluation of surgical technique and some of the theory of it. And then the rest of it's going to be artificial intelligence related. The first thing is, we think we all pretty much have an idea of what learning is like and what's the best way to get learning. There is some theory to this, and this is the Vygotsky's social learning theory, whereby you really divide it up into three different categories. There are things that a learner is not ready to know, and then there are things that a learner can do unaided. And in reality, you want to spend most of your time with your trainees in what they call the zone of proximal development, where this is where they're making the maximum gains with your guidance. So always think about where you are in that trainee's spectrum. What is it that you think they're ready to learn next? The other another tool that we use is the thing called the TAG scale, and that's the teach and demonstrate, advise and scaffold, guide and monitor, solo and observe. I've got to kill this phone. Okay. And this is something that's been popularized by Mike Hagland and his team at Duke. And this is, I think, a very worthwhile paper to review. He actually has an app that has all of this on it, whereby they can evaluate and guide residents in their training. You know, where are they in each individual step in an operation? And they've got lots and lots of data, 400 or 4,800 cases validating this scale. When I was at Rush, I was chair at Rush for 18 years, we used this tool. I think it's a worthwhile tool. It's something that I think that people ought to keep in mind, just a more formal way of keeping track of a resident's development. The next tool, I mean, we all know about milestones. At least in the United States, milestones are a way to keep track of a resident's progress. But the ACGME and the American Board of Surgery, American Board of Orthopedics are moving beyond that now, and they're sort of prompting us to maybe join them in this thing called Entrusted Professional Activities, EPAs. And if you're interested in this, you can go to the website, the American Board of Surgery website, and you can see what they're doing. They're being very, very granular about specific diagnoses and procedures that happen in general surgery. And there's 18 of these EPAs for general surgery residents, where they are very specifically just nailing down what do you need to know about right lower quadrant pain, appendicitis, gallbladder disease, hernia, acute abdomen, small bowel obstruction, etc. So being very, very granular on that, more granular than we are with the milestones. In the milestones, we really have 24 different milestones, but a lot of them are not even patient care related. They're more professionalism. But this is something that is on the horizon that we will be looking at in the next year for neurosurgery. And part of this is really just getting the faculty involved in filling out these evaluations. It really does help move things along. I mean, you need the faculty to be on board with doing these checklists and making sure that you're evaluating the residents as they go through it. And then finally, I just want to talk about two studies quickly here. What makes an expert technical neurosurgeon? I think this is a really, really good paper. This is Hanny Marcus and the group in London. They did this. This is a deep learning analysis, just looking at expert versus novices and just watching video of simulation and trying to really just put words on what makes somebody really good at surgery. And it turns out it really comes down to having your tools present, having those tools working together very closely, having both of your hands in all the time, like the jerks and so on, and getting rid of all of that. And, you know, ironically, of course, is that the experts move their hands more slowly than the novices. So speed is not always a good thing in surgery. It's really efficiency and meaningful motion that really matters. And this is all AI analysis. And you can take that AI analysis and go further with it. And this is the last thing I'll talk about here. This is, I think, a very, very useful paper from this past year in Nature. The first author here is Rakai Yilmaz, who is PhD at the McGill University. He's actually going to be with us, Mayo Clinic, Florida, in a month. We're setting up an AI simulating training facility there, and he's going to come down for a couple of weeks. But this is, I think, a remarkable thing, just proving that an AI simulator that is prompting somebody to get better can be every bit as good as a real-time instructor. So if you take a look at this, they have the simulation going on. The video data is all being looked at. This is all based on prior training data. And then they get real-time instruction about what they're doing. And if there's any problems, they get immediate field feedback. And then they get post-operative feedback. And it turns out that the people in the AI training simulator did every bit as well as the people with the in-person instruction, in some ways did better. So I do think this is a part of the future for us. We'll be setting it up at Mayo Clinic, Florida here shortly. And I think it's a promising thing for all of us to use. So that is all I have for you here today, and I'm happy to answer any questions. Thank you.
Thank you so much. I think we're going to take all the questions at the end, and we're going to move on with Guillermo Checado presentation. Guillermo, if you want to grab the screen, that would be great.
Can I share the screen?
There we go.
Okay. Can you see the screen?
Yes, we can.
Okay. So good evening, everyone. My name is Guilherme Secato. I am a 50-year resident from Brazil, from Curitiba. I would like to thank you very much for the opportunity of having me here. And I'm going to share some experience in the education and training in neurosurgery. So in Latin America, we have a wide range of complexity case. We have a wide variety of pathologies, but we have an imbalance between the OR exposure and the laboratory practice despite it. So this is a negative point because the laboratory practice has already been demonstrated to have benefit in improving the neurosurgical skills, the microsurgical techniques, and the ergonomy and the knowledge of the neurosurgical residents, and more than 50 simulator types have already been identified over the last years. And this is not a new thing. Professor Yazardiu already mentioned and advocated a lot to the residents and the neurosurgeons to go to the laboratory to practice and learn microsurgical anatomy, to learn microsurgical techniques, and pointing that it is an absolute necessity of the trainees to go to the lab to practice. Other challenge that we have in Latin America is a non-uniform neurosurgical routine between the hospitals in the same city, in the state, in the country, between the countries, because we have some hospitals with a lot of resources, other hospitals with less resources. So we have different access to the neurosurgical structure. So how we can overcome this limitation of access of some kind of specific trainings to maybe doing our homework better with the preoperative exams, with the care of each patient. So yeah, Professor Yazardiu, Professor Omefti already pointed a lot to try to extract the most information possible from the preoperative exams of each patient. So here we have a demonstration of a fused CT scan with MRI. We can build a 3D model of a tumor, the neurovascular structures. We can see the postoperative CT scan fused with the preoperative MRI. We can learn postoperatively how the surgical approach was performed, and from the preoperative scenario to try to tailor the best surgical strategy, so we can try to extract more and learn more from the preoperative exams with a with a digital platform. So here another example of basilar aneurysm, we can see the anatomical variabilities of the anterior clinoid process. We can try to build it in 3D virtual models. We can even 3D print these models and have in our hands that 3D model in real size and try to have a better idea of the neurovascular relationship of each pathology. Here another example demonstrating that we can plan in the digital, in a kind of virtual reality, how to remove the occipital condyle, how to perform a kind of transcondylar approach, how to see how we can go ventral to the foramen magnum and try to have from the preoperative scenario a better idea of a kind of surgical approach, and even in the postoperative scenario to learn better how that kind of surgical approach or surgical step was has benefit in that specific surgical case. But the most advanced that we had recently was our microsurgical laboratory that we built with Professor Borba here. We described a kind of setup of laboratory training here with placenta model in 3D printed skulls, so we can develop different kind of microsurgical tasks. Here an example of a subarachnoid dissection exercise. We can pulsate and perfuse that placenta while we engorge the veins and try to separate an artery from a vein, just cutting membrane by membrane. So this is a very good exercise to practice some kind of arachnoid dissection. As well, we can try to perform different types of microvascular anastomosis. We can see how we can handle the needle, the suture thread, the vessel itself, and try the patency of that anastomosis. And by the way, we can also build some types of aneurysms and practice in the lab in a controlled environment, how to clip, how to achieve proximal control, and how to perform the microsurgical clipping without the intraoperative surprise of the first time. We cannot learn in the patients. We have to try and practice in the laboratory before. And here another demonstration of how we can achieve the different types and different maneuvers of arachnoid dissections, here using the scissor, here using 2 forceps. As well, we can see that perfusing the vessels, the arteries, the morphology of the vessels and the arteries changes, so we can have a better idea of the hemodynamic changes of from the intraoperative scenario. We can see in the lab the vessel, how it changes with pressure, with volume, and understand better some hemodynamic changes in the operating room. And as well, we can try how to control bleeding in a controlled environment and try to achieve a better mindset between the brain and heart of that trainee, that resident. So the placenta model is a good, it's a very established model for practice, different kinds of microvascular and microsurgical techniques and exercise. It points mainly all of the domains except for the thrombosis. We cannot, the vessel do not thrombose, it's not, it is an ex vivo model, but the placenta has very good similarity between the diameter of the cerebral arteries with the placental arteries, as well the thickness of the wall of the arteries are very similar with that from the brain ones. But if you don't have placenta, it's difficult to get it. We can try it with chicken wings. It's another model. We can try the microvascular anastomosis in a different way. So we have different models that we can practice. As well, if we don't have microscope, we can train with magnifying glasses to try the dissection exercise as well. This is very interesting because we have this case demonstrating a single brain metastasis of a renal cell carcinoma close to the motor area. There we studying the preoperative exam, notice a kind of particular vein, important vein close to the lesion, and the intraoperative scenario, the intraoperative images is really similar to that one from the placenta. So we have to dissect the arachnoid membranes, preserve the vessels, and the surgical task in the operating room is quite similar to that one from the microsurgical laboratory. What we discussed until now is just microsurgical exercise itself. The tissues are more close to the live one, but we have as well to train the cadavers to learn better the anatomy. So we have to understand the real anatomy, perform the surgical approaches to get a better idea how to perform that specific surgical approach in the patient. As well, here we can understand now in the specimen and the cadaver, the benefit, for example, from the transcondylar approach, how the exposure to the ventral foramen magnum can be better achieved here, despite not only using the virtual planning seen before. As well, we have to practice in the cadavers some surgical approaches, like the COZ approach, that is quite similar to that one that you can perform in the real patient. But if you don't have human heads, you don't have cadavers, it's quite expensive, you don't have access to it, we can try to look for other possibilities. We can go to the anatomy department of the university. We can try to see if there is some specimen there that you can learn. You can try to, for example, use dry skulls. So here we have some types of destroyed skulls. It's not the best, the most beautiful ones, but the anatomy is there. So we can learn and try to practice with this kind of specimen as well. For example, here we are practice the mastoidectomy using a low-cost drill, doing the same steps that we can do with a more expensive cadaver. So we can see and look for the bone anatomical structures, the semicircular canals, the facial canal, the cochlea. We can see all of these structures in this kind of specimens too. And what is interesting, we can also perform a CT scan of this specimen. So see our postoperative imaging of that specimen. So we can observe how much bone we take out, if it was a good approach or not. We can see the facial canal here. Here I demonstrate I violated a little bit. Here we can see in that part. So we can learn better that, you know, it's not the best one, but can try to extract the most information from that specific specimen. If you don't have bone, if you don't have any anatomical specimen to practice, we can try to build it. So we can try to use skull-based, I built a skull-based 3D model. It's a 3D printed one. So it has a lot of anatomical structures. I put some silicon models here, is the sigmoid sinus, the Gacerian ganglion, the internal carotid artery. So we can see some anatomical relationships as well, and try to perform the mastoidectomy by the same way, skeletonizing the sigmoid sinus, trying to remove the air cells and identify the semicircular canals, the sigmoid sinus, and the facial canal, very similar to the specimen, the bone specimen. We can as well try to put some real pathologies and try to skeletonize, try to dissect it, simulating the intraoperative scenario. Like this, in this situation that let's see here, we performed an anterior clinoidectomy in this model in a patient with a carotid clinoid foramen. So we could remove all the clinoid in the laboratory to see the relationships of the clinoid with the artery. As well in the spine, we can use it to try to tailor the best surgical approach in a specific spinal pathology, like evaluating different types of laminoplasty techniques using 3D printing. And here I try to build a simulation using the, let's see here, simulating the microsurgical clipping of a brain aneurysm. It's not working here. Sorry. Simulating the microsurgical clipping of a model of a brain aneurysm, so we can try to evaluate different kind of tasks that we can do in the intraoperative scenario. It's not moving on. Okay. By the time we can use the 3D model in 3D printing to see some similarities with intraoperative scenarios. So in this 3D printed model of a brain aneurysm, we can see quite the similarity of the topography of both A1s with a real intraoperative image, so we can practice and tailor the best surgical strategy to each case. And differently, we can choose another kind of model. We can use, for example, a porcine, a swine head, a pig head. We can try to perform a craniotomy. We can try to drill the lesser sphenoid wing. We can try to find some anatomical structures from the skull base, like the optic nerve, the internal carotid artery. Here we can see the oculomotor nerve, the fourth nerve, and try to practice microsurgery in another kind of model that is not the most famous, the most perfect maybe, but is the less expensive and the most available depending on each situation. And just a demonstration of the CT scan of this big head, for example, demonstrating several anatomical structures that we can use to practice and simulate different kind of skull-based procedures. Thank you very much. Sorry for the time.
Thank you. This is an excellent presentation. Let's move on to our next speaker, Pablo Javier. If you're ready, do you want to share your screen? Thank you so much. And you're muted. So you need to unmute yourself.
I'm sorry, now you hear me. Yeah, so I will talk more about theory of education. Beautiful presentation, Guillermo. I'm Pablo Ager, chairman of neurosurgery of the Italian hospital here in Buenos Aires. I will divide this in 3 parts. First, challenges in Latin America, then how we train neurosurgeons in my hospital, and some ideas for the future. I think in Latin America, we have a big trouble going from book to the brain directly, because training in real models is very difficult. We don't have many cadaver labs. Residents don't practice complex surgery before going to the OR. And this makes learning harder and increases the chance of mistakes. So training depends many times in Latin America on lacking opportunities in surgery, which is really unfair. So on the other hand, residents have high clinical load, so they have limited protect academic time for simulation, reading, and coaching. Many times there's a lack of the order in combination of the combination of cases to which residents are exposed, depends on the hospital or where they are, and training is not always well organized, so skills develop unevenly. There is a lack of control over a lot of neurosurgical residents in terms of number of cases, type of cases, number of residents, learning curves, and so on. So here is the problem of who to trust when lives are at risk. Residents need to learn by doing, but when is it safe to let them operate? Decisions are often based on feelings, not clear rules. And this creates many times confusion and stress because not all the residents are the same. So I will show you how we do it in our hospital, how we try to do it since I am the chairman at this department. I start with this 3D course. 3D is a very good way to understand anatomy for all our residents once a year. Repeating this course every year during residency improves understanding and consolidates knowledge for residents. We perform it on weekends outside normal working hours, and we do it every year. We also have a 2-week microsurgery training course with animal models. We focus on basic microsurgical skills, anastomosis, nerve repair in rabbits, and fine dissection. And this, we do it 2 weeks with daily hands-on practice with expert feedback continually. We record all what they do in a video so we can track the progress. And we do this with our residents of 3rd and 4th year. And this helps build basic skills and make it easier to learn in the operating room. And this is what we do with rats. This is the course with, and these are the videos of what they do in the rats with these bypasses. And this is a very helpful course for our residents. So then they understand better how to use the microscope and they feel more comfortable. We have already initiated with the skull-based course. This is one of the first courses here in Argentina, but we don't have too much skull-based courses with heads in South America. And there the residents can try and learn all the most important approach: stereonal, endoscopic, transplanum, transcellular, transclival, transpterygoid, retrosig, and so on with classes, 3D classes of anatomy, then cases, and then they go to the lab. This lets residents safely practice difficult surgical steps before doing the real operation. I help them connect with other surgeons of Latin America because it's open to all residents of Latin America. And this is how we do the course. This is our lab. You can see you can see how is the course with 3D course and the laboratory, and they do all with us. The other thing we try to do is make like a growing autonomy in our residents with a strong program of education. So they must publish, present at local congress, mandatory, and articles in international journals. Each year, they has like a defined list of procedure that the residents should perform as lead surgeon, like increasing responsibility first with exposure, then closure, and finally some key operative steps. And this is very good because when you combine academic work with clear roadmap for surgical autonomy, helps them to progress safely, and they stay motivated, and they put the theory into practice. And these are some of the paper we published in the last 2 years, our residents. And they also participate and they also organize all our academic conference and clinical seminars, morbidity, journal, surgical case, inpatient, neuroendocrinology. So with this, all these organizations, we plan their preparation for being a neurosurgeon. What I think are the future directions, they have already talked a little bit about this, but I think that repetition build mastery. If you do a lot in 1 week, it's not the best. You need to do it every day or every week. So having a lab with models, with 3D skulls, with virtual reality tools, or some things that Guillermo showed that are very, very useful to learn for residents, and residents practicing every week, getting coaching. They must pass simulation before doing real surgery. That's, I think, very important for learning. And practicing regularly is more effective than doing it intensively, as I have already told you. There are a lot of papers talking about augmented reality. I was doing these slides and I opened my phone and my Instagram disappeared. So, you know that we have that technology yet. This is for ortho residents, not for neurosurgery. But they are offering. So I think the future goes to metrics plus AI assist. So we have to have metrics of practice time, surgical skills, learning speed, OR independence, patient outcomes, academic growth, and this with a feedback of the AI. AI may automatically analyze microscope and endoscope video feeds of our residents, so they can give them an objective feedback and show the value, so they can know what is the value of their training, and they give them clear goals. Because maybe with AI you can detect motion and measures efficiency, and this is, I think, the future in the future directions for neurosurgical residents. So I think it is possible to have this in Latin America, standardized system with clear objective performance metrics, scalable, so you can adapt to different levels of infrastructure. It depends on the hospital, accessible, so you don't need an expensive technology. Now we can have not expensive technology for learning. Resident center, because they are not the same. All residents are different. They have different capacities. So it is important to have an academic level, a good academic level of the teacher, a well-structured plan, and metrics. Metrics are always important in education. So this is a very interesting paper published by Luis. Global neurosurgical education must be inclusive, contextualized, and collaborative. And this article calls for a coordination action among governments, academic institutions, and scientific societies to train neurosurgeons capable to respond to local needs without losing a global perspective. I think this webinar is about this. I thank you for the invitation, and thank you very much.
Thank you. This was excellent. We're going to move along with Juan Luis Gomez from Mexico.
Thank you, dear Professor Germano, Professor Borba. It is a pleasure for me to be here with you. And I want to go to the basics because now we are dealing with a different kind of neurosurgical resident. So they need to know that they need to have full-time dedication to do a neurosurgical residency. And for that, they need an identity. They belong to the institution. They belong to a select group of subspecialists that deals with the brain. They need to have commitment with themselves and also with the patient. And this is going to be gained through a very disciplined system that can give them order, and they have also respect for the patient, respect for the anatomy, for the study. And in order to have success in the neurosurgical career, I think they need to be ready, to be prepared, knowing all the techniques and the anatomy of the patient, in every particular patient, with analysis of the preparative studies. They need to be efficient in all the actions that they do. And most important, they must to be available. If a resident is not available to learn, then he will not take the opportunity that the residency of neurosurgery gives to them. And we need to be leaders with responsibility and sharing the knowledge. So in that way, we can achieve proper success. How can we come to the learning process? We need to study the literature, the classic books, but also the new advancements in neurosurgery that you can find in several journals. Then, as mentioned before, you need to go to the laboratory. In the laboratory, you will learn the different techniques, and also you can have the opportunity to make dissections, cadaveric dissections, or in some cases, as a professor showed before, you can use different models to learn. Then you need to go to the OR. But the most important part for the neurosurgical residency, I think, is the postoperative analysis. After the surgery, you need to have a proper inspiration and vision to have innovative ideas. In that way, you can have a proper analysis of your case and then to apply this for a different patient. And one of the most important things is to learn anatomy. Professor Yasharge showed us that the anatomy is the most efficient tool of teaching. And we can learn a lot of things of the brain by doing this specific white matter dissection of the brain. This gives us a proper understanding of a tridimensional way in which we can access different lesions within the central nervous system. We have applied this in our laboratory in Mexico City, and our residents can have this experience of getting to know properly the brain so they can go through the natural pathways, in that way avoiding a lesion to the surrounding areas of a tumor or etc. So in the laboratory, we can get the proper understanding of the arteries, of the nerves, of the brain parenchyma, and in that way, we can apply this to the patient. It is important to give the patient the tools. They need to learn the surgical perspective on different scenarios. For example, they should be able to know properly the terminal approach, but also its variants. You can go from a terminal approach to perform a COC approach or an orbitocranial approach, but you can also perform a mini terminal approach for selected cases. So they need to know when to apply different techniques for lesions that are located in specific areas of the brain, so you can remove the bone necessarily, for example, in a COC approach, in order to get a lesion without disturbing the brain around. For example, we need to go to the OR in this case for bilateral MCA aneurysms treated through a single approach. This is a left renal approach. So the resident can see that going to the contralateral side after dissecting the cisterns gives them a proper and safe way to reach the contralateral MCA to make the clipping of this bilobulated aneurysm in the contralateral MCA bifurcation. So after learning the anatomy, after studying the literature, then he can watch what can be done in the OR, and later they can perform their own dissections. In this way, we can move from the microsurgical approaches to the new techniques or some indications specific for the treatment of some aneurysms. For example, in this case, a patient with an acromegaly and internal carotid artery aneurysm. This was treated through a endoscopic endonasal approach in the hybrid OR with road mapping technique. So the technology can serve, but the anatomy must be gained in the laboratory before going to the OR. And in this way, we will be able to perform precise lesionectomy, in this case for the pituitary tumor, but at the same time, clipping the aneurysm using this same corridor by knowing which anatomical structures are located around, so we can preserve properly the anatomical structures, and in the same time achieving a proper treatment for the lesion. So to reach this, the resident must have adequate anatomical knowledge gained in the laboratory and then going to the OR and trying to perform these kind of procedures. You can see here the postoperative with adequate clipping of the aneurysm and the complete excision of the tumor, as you can see here, piece by piece, achieving biochemical remission. There are new techniques that are coming around, and we need to know when to use them. For example, in this case, we give the residents the example of incidental MCA aneurysm treated by a transorbital endoscopic approach. So they can see that for a lesion, you can reach in different ways. So after proper knowledge of the anatomy, you can perform a wide opening of the sylvian fissure through a transorbitary endoscopic approach and treating this aneurysm of middle cerebral artery aneurysm. As you can see here, the aneurysm is exposed, is clipped, and then we perform the control with navigation and also with sodium fluorescein. So in this way, we teach the resident that there are several routes to reach a specific lesion, and they need to know all the options that they have to treat a lesion so they can do it properly when it's needed. They need to learn also about the new teaching techniques. We can gain a huge experience from the renowned professors through the academic events that go online. For example, the webinar series of the Yashagel Microneurosurgical Academy. But finally, the most important is to give the resident a mentor. So when they get a mentor, they can have the experience, they can have the knowledge, they can learn from the mistakes that we perform. So it will be easier for them to go in this way of neurosurgery. Thank you very much.
Thank you. This was awesome. And we have our last speaker, Vivek Bukh. Vivek, if you're ready, you want to grab the screen? Thank you.
Yeah, thanks, Isabel. Thank you, everybody. Yeah, sure. Okay, you can see my screen. Oops.
Yes, we can. That's perfect. Thank you.
So thanks for the invitation and for being a part of this very illustrious group of mentors and surgeons in our field. So you know, what I'm going to be focusing on sort of the idea of interfacing machine interfacing in the operating room and how that can be used towards advancing neurosurgical education. Sorry, this is my disclosure. So mainly the challenges for neurosurgical education in the United States, I would say some of these you've heard already, but increases in non-operative time, and I'm not saying these are necessarily all bad things like work hour restrictions and EMR burden, but in some ways they can create challenges for training in the operating room. Other things that we see in particular here, I think, is decreases in operative autonomy. Some of this is legal. Some of this is also just patient care duties that we feel as you know towards our patients and their families, and that's I think is also growing as a growing problem through the training time window. And of course, there's an explosion of new operative techniques and approaches, and this is continuously expanding. So just the body of knowledge that we had 50 or 70 years ago is clearly much different than what we have now. And this will continue to evolve. And so there are, these various considerations require us to be, I think, creative in developing ways to accelerate and optimize intraoperative training and knowledge transfer. So one of the ways that we can think about that is the idea of a surgeon-machine interface. And I call it this because my academic work is in brain-machine interfacing, but it uses similar concepts of how we can really use things in machine interfacing to help accelerate and optimize neurosurgical education and training in the OR. And so one of these would be machine visualization. This is the use of 3D modeling and deployment, understanding patient-specific anatomy and spatial relationships to help guide surgical approaches, and machine intelligence, which is predominantly in the domain of computer vision frameworks, which you heard about a little bit already, and how these can bring tailored educational and training insights and analytics. So with respect to machine visualization, a surgeon's task is extrapolating 2 dimensions that we see in all of our preoperative information and extrapolating that into 3 dimensions. And of course, I show an example of the spine, but this is true no matter what part of the brain or body you are operating in. And so, we kind of can ask the question, why not just visualize everything in 3-dimensional anatomical space? And I put this here. You can maybe just get a faint hint of this, which is actually this patient's own 3D model of their spine. And so we developed an intraoperative open source pipeline to use an OR image that we would take and then generate a 3D model through a series of steps, and then deploy that back in the operating room, which with the model that looks something like this. And and then you can use that towards understanding real spatial relationships in a way that can also in the future lead towards less and less invasive approaches. But it's really the understanding of the anatomy and the spatial relationships is one key to accelerate the ability to train. You can envision a resident seeing this exposure and only seeing what is seen in real anatomical space is difficult. It's difficult, especially early on, to understand what you are seeing. Is it a lamina? Is it a spinous process? Is it a facet? And so things like techniques like this and interfacing with this machine visualization techniques can help provide an instantaneous 3-dimensional understanding of exactly what you are seeing in the operating room with the use of these 3-dimensional holographic and mixed reality AR, VR sort of industry partners. And there's many of these that are emerging, and I think that there is much more to come from this domain. The other interface is really machine intelligence, which is the one that I'm most excited about. I think and starting with the framework of using computer vision to understand real-time anatomy, and computer vision is used all the time now in the real world, as we know, with autonomous cars and other technologies, facial recognition and other things. So so we're working towards building these surgical specific segmentation and foundation models, using and developing what I am calling the surgeon-machine interface here with these various frameworks. And this is just a couple of examples. One is in a spinal cord dural AV fistula video. These are just my own procedures that I had recorded and started doing this work in the lab. And here's a microvascular decompression. One's microscopic, one's endoscopic. Spine versus skull base or brain. So you can see that it's agnostic to the type of video and the video input, and And ultimately, you know, again, it's a matter of understanding, to at least to start with, the understanding of anatomy and spatial relationships, much like what we were just talking about with holographic modeling. However, the difference here is that it provides the information of added information of real-time, you know, real-time use of the instruments and the interfaces with the anatomy that are occurring during the course of the case. So these are ways that we can start developing approaches of machine intelligence for education, and this is not just work that we've done, but also others and friends and colleagues. And so, you know, the idea here is really that you can do things like instrument tracking, as well as phase of surgery or scene recognition. And this gives you ways to create objective metrics for you know, objective skill assessments, as well as creating sort of a stepwise approach towards training and making that much more quantitative, as opposed to how we do things right now, which is much more qualitative. You know, again, this type of an approach, it really requires data. I mean, that's the key. That's how any of these algorithmic approaches will become robust and powerful. And so we did start something called the Smart Surgeon Collaborative, which we're now across multiple centers and actually multiple continents. We're always happy to interface with those that might be interested in contributing and helping out in the academic mission of all of this work. And so, just with that, I'd like to thank the team in the lab and all of you for your time.
Thank you. And this was really a great way to bring it all the way back to a full circle. I would like to start ask a question to Rich Byrne. It was texted to me during your talk. And basically the question revolves around the biggest change that you have seen during your training and the biggest change that you foresee for this or maybe the next generation of neurosurgery residents.
Well, I mean, during my training, that was back in the Stone Age. I mean, I would say image guidance. That was probably the biggest, most transformative thing. We already had the microscope. We had all the other CUSA and all that sort of stuff. I would say image guidance was the biggest transformation. And what I think is coming is, I mean, it's already coming. Our residents are already using AI to prep cases. My daughter's a fourth-year medical student going into the match this year for neurosurgery. They prep their cases with AI. They don't. There's nobody's going back to look at any surgical manual. Nobody's even Googling anymore. It's all AI based. We've heard several presentations. The VEX talk went over it as well. I mean, this is the way it's going to be. And I do think that we're going to be training our residents in sim trainers. And they are going to get much better with their hands in small places in sim trainers. And I think some of the other things that the other speakers talked about with, you know, prepping anatomy with VR, AR is going to be a part of it too. I think the residents are just going to start off better with better preparation, better hands, better microsurgical skills that we all learned the hard way on patients, you know, decades ago.
Thank you. And this is a question for all the speakers. Some of you gave beautiful demonstrations of cadaveric dissections and or dissections on placenta and other non-human, I mean, not brain related things. Do you think that AI will completely remove the need for all of the above? And can we train just with that? Let's go around the table. I see Juan Luis shaking his head. Go ahead. You're muted.
I think artificial intelligence is going to be a great tool, but I don't see a possible scenario in which this can be enough to give the resident the tactic perception of the brain. Fiber dissection techniques in the brain, the placenta model that the Dr. Secato showed us, or different techniques are necessary to give the resident the integration with the hands and the eyes, so they can go inside the OR, inside the surgical field. So the proprioception that you gain with these exercises, I think it's mandatory to reach a good neurosurgical level.
Pablo, what are your thoughts? Are we going to do without?
I think we are in a change moment. So I think resident must learn as usual, learning microsurgery, anatomy, as Juan Luis and Guillermo show, but they have to be prepared to use AI or robotics. I think if you see general surgery, gynecologists, they are all using robotics. So maybe robot give us more perfection in our movements, maybe, I don't know. We are changing now, the world is changing, and I think our residents must be prepared for both sides, because we don't know where we are going. I think we really don't know where we are going.
Vivek, you were pretty strong on AI, so
Yeah,
what are your thoughts?
my view is I think that I think it segregates a little bit in terms of practice versus knowledge transfer. I think AI will be very, very good at knowledge transfer. You'll have the ability to understand things much more clearly, much more efficiently with the use of these types of techniques. But it doesn't give you practice, I think. So maybe that's where I can see the use, just like Rich pointed out. I mean, the use of simulation technologies, as those improve with their haptics, can be very, very powerful for the practice piece, as well as cadaveric dissections and surgical approaches through cadaver labs. So I think there's going to be a role for both in their own way.
Excellent. So I see 1 minute before the hour. I would like to invite Professor Borba to give a few closing remarks.
First of all, I say thank you, AANS, for the opportunity. Thank all the speakers. I'm very proud of our team, of Latin American team. We select the 3 countries. This young guy, our resident, Guilherme, that is doing a beautiful work, doing the lab. His word is commitment. Commitment, dedication. It's make the difference. What make your future is you. It's not the AI, it's not the facility. You make your future. And the same is the education. What's the difference in the rich country and the poor country? Is the education. And the neurosurgery around the world is changing a lot. And today, with the education be worldwide, everybody can have access. I see this young guy doing beautiful dissection in the lab, and also the people, beautiful 3D reconstruction in AI, all the technology. You can have everything, but not have commitment with your duty. You'll not make the difference. We are a neurosurgeon to treat patients, to treat people. It will make the difference. Thank you, Juan. I think Mexico is very well represented, as Argentina, as a young guy from Brazil. I think Latin America can show that you can do a neurosurgeon in very high level, in every corner of this continent. Depend of the people. And the people of neurosurgery with support of FLANC is going our day by day, going better. Thank you very much for the opportunity. Oh, just to say something. Today you have the information that the most beautiful educational platform that the AANS is open internationally with very low price, that all the world now can reach the educational platform of the AANS. Thank you very much, sir.
Thank you, Luis, for this great closing remarks. I would like to thank the AANS Global Committee. Every single member put a lot of effort into trying to really all work together, looking at opportunities. And this example tonight is a good one, showing that if we all work together, if we learn from one another, we can care for our patients globally. Thank you, everyone, and hope to see you soon at the next meeting.
Thank you. Thank you. Really appreciate it. Thank you.
Thank you very much.
Tchau, tchau. Mandou bem, hein, Guilherme? Mandou bem, mandou bem.
Muy bien.
Ah,
muy
tava
bien.
nervoso, né? Deu certo.
Estava nervoso, né,
Muchachos.
cara?
Eu tava, né?
Nos vemos en Perú.
Bonito. Muchas gracias. Gracias,
Gracias.
Pablo.
Gracias,
Era
gracias.
la idea, mostrar bien para ellos que nosotros podemos hacer bien, ¿no?
Gracias, Luis.
Listo.
Vai,
Chao.
vai,
Gracias.
Pablo.
Chao.
Luis.
Chao, chao, chao.
Tchau, tchau.